Good afternoon, everyone. Thank you for joining us for this congressional briefing hosted by the Food is Medicine Institute at the Friedman School of Nutrition Science and Policy at Tufts University. I am Emily Callahan, and I serve as the Director of Policy Strategy for the Institute. The title for this briefing is in the form of a question, and it is GLP-1 drugs plus food as medicine, a new recipe for success in treating obesity? On behalf of the Institute, I would like to thank Senator Cory Booker and his office for their support in reserving the space for this briefing and helping us with many details to work out the live stream technical support for this event. And I also want to thank Senator Bill Cassidy and his team for preparing video remarks, which you'll see in just a minute. We have a wonderful panel here to discuss the intersections between GLP-1 receptor agonist drugs, food nutrition, and obesity. The panel will be moderated by Danielle Nierenberg, president of Food Tank. Danny is a renowned researcher, speaker, and advocate on issues related to our food system and agriculture. And Food Tank is a global convener, thought leadership organization, and creator of original research impacting the food system. Danny, I'll turn it over to you to kick off the panel.
Thanks so much, Emily. Hold on. Thanks so much, Emily. You can hear me now, right? I'm so pleased to be here again. My name is Danny. I'm part of an organization called Food Tank. Our mission is to really highlight stories of hope and success in food and agriculture systems across the globe. We do this with the aim to inspire, motivate, and ultimately activate how we produce and consume food. I'm really thrilled to be here and so excited for this session around GLP-1s and food as medicine. We've seen so much excitement and some controversy around this recent class of drugs like Ozempic and Wegovy, that can help patients manage diabetes and weight loss. But there are also many questions about the side effects, the very high costs, and long-term patient care. And we're seeing differing opinions in the news every day. So we're really here to take a deeper look and really dive in. During this conversation, we're going to talk about the good and the bad of GLP-1s and some potential solutions that can complement pharmaceutical treatment options and help us reduce the impact of their side effects. And we have a really amazing group of panelists to help us do that. So I am really pleased to introduce Dr. Pat Gleason, the Assistant Vice President of Health Outcomes at Prime Therapeutics and an adjunct professor at the University of Minnesota's College of Pharmacy. Thank you for being here. We have Dr. Alka Gupta, the CEO and founder of Blue Rock Care, the Chief Medical Officer of an accountable care organization within the CMS Innovation Center's ACO research, and a clinical assistant professor of medicine at Weill Cornell Medicine and George Washington University. Thank you so much for being here. We have Dr. Stephen Heimsfeld, who is a professor and director of body composition metabolism. He is a professor and the director of the Body Composition Metabolism Laboratory at the Pennington Biomedical Research in Baton Rouge, Louisiana. You understand why it's a mouthful, right, to say all these titles. We have Phyllis Ruth Jackson, who is a resident of Southeast Washington, D.C., and a student at Trinity Washington University, where she studies healthcare. Welcome, Phyllis, thank you. And we have Dr. Dariush Mazafarian, a cardiologist, public health scientist, and the director of the Food is Medicine Institute at the Friedman School of Nutrition Science and Policy. I'm a proud Friedman School alum and so honored to be here. So I'm going to just jump right in with Dari. And I'm wondering if you can sort of give us, I like to call it a state of the plate, the state of GLP-1s. Where are we with them now? What do they actually do?
Yeah, well, I think it's important to highlight that there is good and bad. And so often there's a battle between sort of the public health and nutrition and lifestyle folks saying these drugs are awful and we shouldn't be using them, and then sort of focus on the nutrition and public health, on the pharmacologic medical side, saying these drugs are the only answer we have. You know, that's not really the state of the truth. There's really good things about them, and there's really big challenges. So the really good thing is they can really work. They're the most effective drug we've ever invented for obesity treatment. And these are going to be the single biggest class of drugs, the single biggest blockbuster drug ever invented by humankind. I mean, the numbers and the dollars that are going to go into these globally are astonishing, because on average in randomized trials they give weight loss of about 12 to 18%, which is much larger than anything that's been previously seen. And in real life, if you look at outside the trials in real life practice, they give weight loss of about 10%, and 10% is meaningful weight loss. And I want to emphasize that it's, at the same time, these aren't going to cure the obesity epidemic. First, 10% weight loss is not going to make obesity go away for most people. 1 in 11 American adults weighs more than 300 pounds. So 9% of it. And so, if you go from 300 to 270, you're much healthier, but you still have to weigh 270 pounds. Second, there's a lot of side effects of these drugs and a lot of challenges to taking them, cost and access and side effects. And so, as we'll hear, most people don't stay on them, even at a year. And then the weight is regained if there's not kind of a wraparound structure of support to help with the weight maintenance. And so you have the combination of an amazing drug that can really work wonders for some people that costs, an arm and a leg for the healthcare system, isn't accessible to many people, isn't associated with long-term compliance in most people, and then weight is regained. And so I think what this panel is, hopefully what we're going to try to talk about is how can we use these drugs in a smart way to get all the bang for the buck we can, but then combine them with other approaches to minimize these negative aspects.
That's so great, and that combo will be, I think, essential to this panel. Before we continue, I want to share a video from U.S. Senator Bill Cassidy of Louisiana, who unfortunately couldn't join us in person, but still wanted to give us a video contribution. So I'm hoping we can play that.
Hello, United States Senator and Dr. Bill Cassidy here, representing the great state of Louisiana. It's an honor to share words with you today during your congressional luncheon briefing. As a doctor, I've seen obesity's effect on a person's mental and physical wellness. There is a clear need to combat the obesity epidemic across the United States. Now, when I taught medical students, I compared obesity to the Greek mythical monster, the Hydra. So here's the obesity, and here would be the risk for strokes, fatty liver, heart disease, gout, bad hips and bad knees, and I could keep going. And just like the Hydra, sometimes you cut off that head and 2 more would grow back. So yes, you might deal with one aspect of the metabolic syndrome, but then 2 others would pop up, including cancers that result from all these other things. Well, like the dangerous and persistent Hydra, these diseases are the leading causes of preventable death in the United States. That's why I'm working to address obesity through bipartisan legislation like the Treat and Reduce Obesity Act, or TROA, and the Medically Tailored Meals Home Delivered Meals Demonstration Act. That's quite a mouthful. So TROA expands coverage of new healthcare specialists and chronic weight management medications for Medicare recipients. The Medically Tailored Meals Home Delivered Meals Demonstration Act recognizes that when people have a diet appropriate for their chronic medical condition, it may reduce hospitalizations. So 62% of seniors live with 1 or more chronic conditions, and research shows tailoring a meal to their particular health need can be a cost-effective strategy. Thank you for being here. Your work is indispensable. Together, we can ensure that patients have access to comprehensive obesity care. That sort of care that allows them to live a longer and healthier life. And when it happens, it will happen because of your dedication to addressing these issues. So have a great, enjoyable, and productive meeting. Thank you.
Thanks to Senator Cassidy and his team for making sure that he could join us, at least virtually. So, Stephen, I'm going to turn to you now, and if we can talk about, there's so much attention placed on these drugs right now. They're like the silver bullet that everyone's talking about. But this is not the first time that a class of weight loss drugs has been touted as sort of something that's going to save us all.
That's correct. First, let's make it clear that obesity is not caused by a lack of willpower. It's a chronic relapsing disease of excess adiposity. And in that context, pharmaceutical companies have tried for many years to develop effective drugs for managing it. And we can think of many examples of, for example, fen-phen years ago was touted as a wonder cure for obesity. The exuberance phase faded quickly when side effects became clear, and it disappeared. And that is true for many other previous attempts at weight control. Now, enter the GLP-1 receptor agonist. As Dari mentioned, these are really remarkable drugs that not just manage obesity, but all of the chronic diseases Senator Cassidy mentioned. And we're in the exuberance phase now. But what we're learning is this is a lifetime condition that requires management, not just the pharmacologic level, but to the lifestyle level. And we're already beginning to see people are dropping off the drugs, the cost is very high, and the side effects are appearing. For example, people don't eat adequately when they're on these drugs. They require improved vitamins and minerals and other components like that. And also they lose excess muscle mass. When you lose weight, you lose not only fat, but you lose muscle. And that muscle loss can be prevented if you take adequate protein and you do an optimum amount of exercise with it. So we're learning that this disease requires not just pharmacologic management, but lifestyle, and perhaps lifestyle only at some point once you reach a maintenance stage.
Absolutely, it has to go hand in hand at first. Alka, if I can turn to you, I'm wondering what you consider when a patient comes to you and, is experiencing obesity or experiencing diabetes, and, how you decide whether or not to put them on this drug.
That's a big question. It's a great question. At the end of the day, it's always going to be a joint medical decision
Sure.
between patient and me or whoever that practitioner is. But we definitely take into account a lot of things, including how feasible each one is. And I think for the GLP-1s, that answer is a little bit more straightforward, right? As doctors, we're very used to prescribing medications and maybe helping them jump through a couple of hoops and then teaching them how to administer that medication. I think the lifestyle changes, like how to optimize how you eat and drink every day, how you move every day, that sometimes raises some question marks, like how realistic is that? And can you change the way you've been living your life for the last 50, 60, 70 years?
Sure.
And I think the answer is absolutely yes. Many people can change those things, but only if we've developed an ecosystem around the patient, around the practice, ideally involving community, to help enable that. If it all hinges on one visit every 3 months with a doctor, then we're kind of setting ourselves up to fail. We need the rest of that infrastructure that's full of professionals, community organizations, and others.
You're right, it has to be that full ecosystem. Phyllis, if I can turn to you, you have described sort of being on a health journey. And as someone who has taken a GLP-1, can you talk us sort of about your personal experience and why you decided to start having it be part of that health journey?
Yes. Can you hear me?
Yes.
Yes. Good afternoon, everyone. This is my doctor, Dr. Gupta. I started with Dr. Gupta last year, and when I went to see Dr. Gupta in regards to a consultation, I had a high A1C level, 7.7. I also was very overweight, hitting close to 300 pounds. And I needed to change my lifestyle. I needed to change some ways that I was eating and also exercising and just getting myself together for a better healthy lifestyle. So I had a consultation with Dr. Gupta, and she discussed with me Ozempic, exercise, nutrition, and other healthy lifestyle topics that we discussed, and I took her advice and I did it. I started on Ozempic in March 23rd. I incorporated exercises, water aerobics 4 days a week for an hour, sometimes an hour and a half. I've also incorporated strength training with my water aerobics. I've learned how to better shop for veggies and fruits. That's what I'm eating now, basically veggies and fruits. A lot of the foods that I was eating before, I can't tolerate it anymore. And I'm feeling a whole lot better. Stress levels are definitely down a whole lot. So it was a team that helped me with my health journey, and I'm still on the health journey, and I'm going to be on the health journey for a long time. But again, I want to say thank you, Dr. Gupta, and your team for getting me started on my health journey.
And I want to say from talking to Phyllis earlier, she's really done a lot of her own research. She's taken on a lot of this herself, finding resources in her community, and listening to her exercise schedule exhausts me. It's so great, Phyllis, that you've been able to do this. And I wonder, this combination approach that we've been talking about, it includes that community that Dr. Gupta mentioned earlier. Can you talk about how the community resources have been helpful to you?
Yes. With me doing research with helping me with my health journey, I didn't have much money. I don't have much money. I'm on a fixed income. I'm retired. I'm in school. So I looked into other resources, the Department of Parks and Recreations. They have a wealth of programs for the community. And I looked at the events, looked at their schedule, and I joined some of the programs under the Department of Parks and Recreation for my exercise activity. University of District of Columbia Gerontology Department has a nutrition program. I registered with the University of DC in regards to the nutrition program so that I can learn more about nutrition, healthy eating habits, how to prepare healthy foods. I've also looked into community organizations like the WELL program that has gardens in our community where you can learn how to garden, learn how to plant food, grow food, and also cook the food. So there are several organizations and resources in the community that really helped me, and it didn't cost me anything at all, nothing at all. Also, too, on the back of my insurance card, I called member services to also get resources from the insurance company or the insurance company that I'm with, and they also recommended a whole lot of resources for me so that I can have a better health journey. So a lot of things that I did, it took some research, but it paid off. It paid off.
It certainly did. Thank you for sharing all of that, Phyllis.
Yeah, can I
course,
just
yes.
make a point? So we have Dr. Gupta here who is trained and certified in lifestyle medicine, which is quite unusual. She's also 38 weeks pregnant right now and sitting here and being incredibly lucid and engaging, which is also remarkable. And then we have Phyllis, who was able to go out, and to me it sounds incredible that she was able to go seek out and engage and do all these resources. We have them on the panel because they're the exceptions to the rule.
Right.
They're literally exceptional, and this is not the standard medical practice.
Right.
And so this is, I think, the approach that should be, that people get a wraparound from a doctor that understands nutrition, is
Sure.
trained in nutritional lifestyle, and then in addition to getting a drug, gets the resources, and hopefully not having to find them all themselves from 8 different places,
Right.
but have them in a structured package as part of their healthcare.
Absolutely, and that makes me want to ask both you and Pat, because they are the exception, not the rule, how do we create a system where there's more equity and access and honestly justice? And I'm wondering, Pat, if you can go first.
Yeah, sure. Thanks. Great to be here. I work for Prime Therapeutics, a pharmacy benefit manager owned by 19 nonprofit Blue Cross Blue Shield plans across the U.S., servicing 1 in 10 Americans with their pharmacy benefits. I'm a pharmacist, and I'm a health services researcher, and what we do know is that obesity is more of a disease than just the drug therapy. It's a disease that requires lifestyle modification, wellness program. As we've just stated, and Phyllis has nicely shared, it's so much more than prescribing that GLP-1. You need to have the team, and you need a team that includes a dietitian, coaching, a pharmacist, a physician, a full service suite in order to succeed. And I'm old enough to have been around when nicotine replacement came out for smoking cessation, actually practiced internal medicine, teaching clinics at Pitt and University of Minnesota. Smoking cessation is the same thing. You have a habit. You have to make those behavioral changes, and then the drug therapy is ancillary. So it is additive to that complete suite of activity. And I need to add that as a health services researcher in my job, looking at drug therapy and trying to ensure it's most cost-effectively used, we looked at over 3,000 individuals in newly started GLP-1 therapy for weight loss without diabetes and followed them for a year to see how long they stay on therapy. And after a year, we have less than 30% still on therapy. And we've now followed those individuals for 2 years, over 3,000 individuals insured with commercial insurance. And we have 1 in 7 still on therapy. So that pretty much tells you we have a problem of medication adherence. These patients, for the most part, did not receive any lifestyle modification or behavioral health programs or wellness programs. We can improve that. We can do better. We have to have these programs to help us.
Absolutely. Dari, can you talk a little bit about the cost of these drugs?
Yeah, I mean, the cost is the elephant in the room, so to speak. One of the misperceptions that I constantly hear when I speak to folks, whether it's patients, doctors, policymakers, really smart people from around the country, they know obesity is super expensive. They've heard that obesity is one of the most expensive and costly conditions we have. So they assume that this drug that's going to reduce obesity will save money. And the drug is so expensive that that's just not anywhere close to the case. It would have to be probably 1/10 the cost to even be cost effective, which means you're getting a good buy for your dollar. To be cost saving, it would probably have to be a 20th or a 30th of the price, given how expensive the drug is. Right now, even with maximum negotiated discounts, it's probably about $8,000 per person per year for this drug. And so if you just take the obesity indication, there's also diabetes and also cardiovascular disease indications, and soon there will be others. If you just take the weight loss indication, 93 million Americans qualify. And so even at discounted prices, if every American who qualifies were on this drug, it would cost at least $600 billion per year in drug spend. And that's what we spend on every other pharmaceutical drug combined in the United States right now. So this one drug would double our nation's drug spend, and that's just not going to happen. It's just impossible, right? And then if you put on top of that you've spent $600 billion for the year or for 2 years, and then eventually most of the patients are off the drug and regain the weight, you've not only spent that money, but you haven't spent it effectively.
Right.
And so that cost is outrageous. And I'm an optimist, a glass half full kind of person, as we talked about. That cost is now driving health systems and payers, and I hope legislatures and policymakers here in the room to understand that these other things, these wraparound lifestyle services that Phyllis is talking about, that Dr. Gupta is talking about, are not that expensive. And so if we can actually integrate those into care so they're covered by healthcare, they're prescribed by clinicians, they get food as medicine treatments, they get exercise prescriptions, they get supportive therapy, that we can actually finally have a really cost-effective approach to treating obesity that combines the best of the GLP-1s with wraparound lifestyle services integrated into healthcare.
Sure. So I'm not an expert on this issue, but what you're describing to me seems so common sense, and in all the different ways, in terms of patient-client care, in terms of giving doctors sort of more empowerment to not only write prescriptions for drugs, but to do other things. Why isn't this happening more if it makes so much sense? And this is really a question for the whole panel. I'll get you.
I think it's, I think that idea of, can you change lifestyle or not? And can you do that permanently, especially after you've lived a certain way for a long time, is a big question. And every person also deserves a different approach when trying to answer that question. Listening to you talk, Dari, another patient comes to mind also who elected not to take GLP-1, or for that matter, any medication. We met a couple of years ago when he was in his 60s, and he had not been seen by anyone in healthcare for decades. And so this was truly starting healthcare later in life. And unfortunately, at our second conversation, we were discussing that he had floridly uncontrolled type 2 diabetes. Ms. Jackson mentioned that her hemoglobin A1C was 7.7. At 6.5 is the threshold for diagnosing diabetes, and his A1C was 11.5, at which point most people recommend starting insulin plus or minus other medications. But he wasn't open to that, and we spent the rest of that visit talking to him about how to set up a plate, exactly how much physical activity he'd have to do to achieve significantly lower and safer blood sugar levels, and setting it up with devices so that we could monitor him safely from home. So when he checked his blood sugar or stepped on a scale, our team could see that. We could provide feedback. We could add medications if needed in between visits. And just setting up that structure that made this like an okay and safe plan. And 3 months later, his A1C was down to 6.7
Right.
from 11.5 with 0 medications. Now, I'm not saying that is possible for everybody. It's not realistic for everybody, but for this patient, it was. And if we're talking about the monetary value of that, I mean, we could be talking about hundreds of thousands of dollars of unnecessary healthcare spend that he's achieved by choosing path B instead of the path more traveled.
Sure, it's clear there's no cookie cutter approach to this, and I'm wondering maybe you can talk about why this patient, this male patient, decided not to take the drug. Was it the fear of the side effects?
I think it's a complicated question. I mean, clearly this person hadn't engaged with healthcare in a long time.
Sure.
So I think there's a lot of mistrust, a lot of fear of the healthcare system. For example, I think if he had left that appointment and we had said, no, you've got to start insulin, here's your prescription, that's the only option, I think there's a very high chance he wouldn't have come back.
Sure.
And yes, I think fear of injecting a medication when you've only just learned about a diagnosis, I think that's tough too.
Absolutely. Phyllis, I wonder if you want to comment on the side effects and how you sort of work to overcome them.
Yes, I didn't have many side effects, and that was because I was proactive with wanting to take control of my health and my health journey. The only side effect that I experienced was constipation. And with constipation, I changed some of the foods that I was eating and incorporated a whole lot of water and lemon water, ginger water, a whole lot of vegetables, different types of vegetables, and fruit and herbal teas. But after I changed my diet, which was almond milk, because I was doing an almond milk smoothie in the morning with oatmeal and fruit, and then I would go to my exercise class, and I'm like, this is not working for me. This almond milk and the oatmeal and the fruit and veggies, the fruit, and it just didn't work. So after I changed my diet with peppermint tea and spiced tea, and I would do like 2 oranges in the morning time and a little slice of watermelon. And then I would go to my water aerobics class and my strength training class. It helped me out a whole lot. And I'm not experiencing any more constipation at all. I'm feeling good, and I feel a whole lot much lighter.
Oh, that's great.
Can you talk about what's happened since your original prescription with this package of lifestyle and the medication? Where are you today in your journey? Yeah.
Well, when I first started the journey, I was weighing 297 pounds. I'm down to 281 pounds. I've lost 16 pounds. I have changed a whole lot of my nutrition habits in regards to eating. My serving portions are much more smaller. I have incorporated a whole lot of vegetables and bean soups, salads into my diet. Also, fruits and veggies. I was just telling one of the panelists, I think I'm eating too much watermelon because the watermelon is very good this year. But that's where I'm at with the change with the medication and also food and exercise.
And your A1C was 7.7, and what is that now?
7.7, and today, when I had my labs done last week, it was 6.4. When I had my labs read to me, it was 6.4.
Congratulations, that's
So
amazing.
I'm looking to get down to at least 5 with the continuing health journey that I am on. I'm going to stay on that journey. I'm not going back. I'll be
Fantastic.
66, and next Monday, I'll be 66.
Happy early birthday.
Thank you.
We're so excited to hear your story. Thank you so much. Stephen and Pat, you both have been looking at me, and I want to make sure that you get in here.
I'd like to take a little bit of a step back. And we've been talking about pharmacotherapy and lifestyle therapy as if they're two different things. In fact, they're really complementary. And we've all mentioned lifestyle. Maybe I could ask Dari, exactly what do you mean by lifestyle in the context of pharmacotherapy? I think it would be helpful for people to understand. It's not just diet or exercise, right? There's a lot more to it.
Yeah, well, so I mean, I'm a cardiologist, and the reason I got into this field of nutrition was in my 11 years of training in medical school, internal medicine and cardiology, I got maybe an hour of food and nutrition, and I don't think anything about physical activity and nothing about sleep or mental health. And yet those 4 things, poor nutrition, physical activity, poor sleep, and mental stress, are the foundation of all disease in our country by far. And so if you wonder why our healthcare system costs $1 in 5 in our economy and is only growing, it used to be 5% of the federal budget. Now it's 30% of the federal budget, squeezing out all of their priorities in Congress and so on. It's because we're not addressing the root causes. I love the example of the Hydra that Senator Cassidy, but actually the Hydra is not even obesity. The Hydra is these 4 kind of foundational lifestyle conditions. And so if we want to, now that we have 43% of adults with obesity and another 10 or 20% with overweight and multiple metabolic complications, if we want to address that, we have to address these fundamental 4 things through the healthcare and through other pathways. Healthcare is not the only approach, but absolutely healthcare is really important. And so I think for GLP-1s, if you just put lifestyle against GLP-1s, for most people who don't have an incredible lifestyle trained doctor like Dr. Gupta, and incredible willpower and motivation and vision like Ms. Jackson, GLP-1s are going to win. So it's not a head-to-head battle. It's about using them together. And so what I think would be remarkable is for GLP-1s to be prescribed with wraparound lifestyle. And for this program, I think switching to think about healthy foods, in particular foods that are high in healthy plant fats, low in starch and sugar, high in fermented foods that are really good for the microbiome, high in fermentable fibers that are good for the gut microbiome, high in the thousands of phenolics. You mentioned the teas, lemon, thousands of phenolics that are good for the gut microbiome. If you have a gut microbiome satiety diet, you add to that strength training to prevent the lean muscle mass. That's probably the most important thing with GLP-1s, is not going out and jogging 10 miles, but the strength training to maintain the muscle mass. Adequate sleep, 7 to 8 hours. So I'm looking at the staffers, 7 to 8 hours. Sleep is sort of the adequate sleep. And then mental health, which has to do with different things for different people, family, community, purpose in life, meditation, yoga. If you give that person a wraparound service, not just, telling them to do it and setting them off by themselves to do it, but giving them a program that's covered by their insurance, then I truly believe, first, most patients would be able to stay on GLP-1s, at least to get the effective weight loss through 2 years. Once they have the weight loss, it plateaus. So weight loss is not continuous. And so weight loss plateaus at about 18 months. And so now you have a 40-year-old, a 60-year-old, a 16-year-old who's met their weight loss goals. Are you going to give them this drug for the next 40, 50, 60 years at $8,000 a year just to maintain them? Like that, we just can't, it's just impossible, right? So now I think a reasonable number of patients could come off the drug and be very successful for the rest of their life. Another proportion of patients would come off the drug and be successful for 3 years, 4 years, and then maybe need to go back on the drug for a year or so. And then others may just fail and need to stay on the drug, but hopefully that'll be a small minority. And so I feel like this combination could be very powerful. And I just want to give the example of, right now we prescribe drugs for patients, and in and of itself, many patients don't take the drugs we prescribe, but they still have a system. They have a system. They have a prescription. They go to some place that is close to them to fill it at a pharmacy. Their insurance pays for it or pays for most of it. Imagine if we gave them that drug prescription and they didn't have a pharmacy within 10 miles of their house, and if they did get to a pharmacy on 3 buses, the drug wasn't paid for. How effective would our drugs be? And yet, when doctors tell patients, you need to stop smoking, you need to sleep, you need to do exercise, you need to eat better, here's your verbal prescription, there's nowhere to fill it, and for many Americans, and even if there were somewhere to fill it, it's not paid for. So we have a crazy system where the most important thing that we should be prescribing is not covered by healthcare, which is these foundational kind of lifestyle things. And that's where food as medicine comes in, and hopefully we can actually talk about what is happening in the food as medicine space.
Absolutely. Pat and Stephen,
Yeah, well, just to build upon that.
Sure.
I mean, the ask is actually quite simple here for policy that pays for and encourages lifestyle modification and wellness programs. And that is the first step before going to the prescribing of the medication. Medications, as we know, have side effects. Medications have cost. And with the GLP-1s at list price, and we're talking $1,000 a month. So, and it's already been pointed out, well, we don't need anecdotes. We've got a lot of evidence that you start with lifestyle modification and wellness program. If that doesn't work, then you move to drug therapy. You don't just start with drug therapy. I mean, there are some exceptions where you're going to start with drug therapy at the extremes along with lifestyle. But for the vast majority of people, they should be a lifestyle modification program first, along with a food as medicine process, addressing the food that they're eating and food as medicine delivery, and we'll talk about that next. But I can't help to emphasize that it's a stepwise process.
sure. Stephen, do you want to comment before I turn?
Well, the drugs are only approved with lifestyle programs. The FDA approval, if you look at them, in conjunction with lifestyle.
Great. One thing that strikes me as I'm sorry, go ahead, Olga.
I just wanted to piggyback off that. Like when we say lifestyle program, what we need is something more robust than what's already in guidelines, right? We already see dietary and other lifestyle modifications recommended as part of management of high blood pressure and high cholesterol. But I think we all know what actually happens in practice.
Right.
So we're talking a more intensive delivery and deliberate delivery of those lifestyle modifications.
Yeah, and that really leads me to my next question. What strikes me is that we need both intellectual and physical infrastructure for this to work. And I wonder if anyone wants to comment on that. How do we move from where we are now to where we want to be?
Well, I can talk on the food side in particular. We launched a Food as Medicine Institute at Tufts about a year ago to bring together cutting-edge research, convening of multiple stakeholders across the healthcare, private and nonprofit sectors, and also government advocacy and bringing education to those who are making decisions at the federal and state level. We've been talking about food as medicine, and others have been talking about food as medicine for a decade, but now there's really enough evidence and movement to create structure to integrate food as medicine into healthcare. And so when I say food as medicine, when we talk about the Food as Medicine Institute, we're not just talking about the broad concept that food is foundational to health. We know that to be true. We're talking about structured food-based nutritional interventions that are integrated into healthcare, prescribed by doctors who are educated about nutrition, covered with RDN counseling who can give supportive nutrition and culinary education, and then covered by health insurance. And that's really happening. It's happening now in demonstration projects across the country. It's happening at the VA in a pilot, at the Indian Health Service in a series of pilots. It's happening in Medicaid across 11 states, soon to be 14 states. It's happening in Medicare Advantage programs. It's happening in some commercial plans. But it's all a patchwork. It's all a patchwork. And so what we really need is Congress to identify these incredible winning signals and catalyze them and move them forward through a series of policy actions. And so some of the programs include things like medically tailored meals. So for the people that are really, really incredibly sick, they actually get usually about half their meals for the week fully prepared for anywhere from a few weeks to many months or a year or longer, depending on how sick they are. those meals keep people out of the hospital, keep people out of the emergency room, keep them healthy. And actually, if you give them to the right patients, save money. They actually really do save money, even accounting for the cost of the program. And then for people that are able to cook or shop, and aren't quite as sick, there's programs like medically tailored groceries or produce prescription programs, which are either, let's say, a digital card where you can go to the grocery store and pick up food from certain curated categories of foods, or, for example, we work with Instacart, and Instacart has something called Fresh Funds, where they have curated categories of foods that a commercial plan or a Medicaid plan could say, you can go online with Instacart and get these delivered to your home. And so these are real programs that are happening. And I think the advent of the GLP-1 era, and it really is going to be an era, allows us to finally start to put these things together. And the cost of the GLP-1s means that adding these programs will actually save us all money, and make us healthier. And lastly, and I know, Danny, this is important to you, so we should talk about this more. When I say food is medicine, I'm not saying food is only medicine. I've never said that. So food is also joy. Food is also taste. Food is also family and culture and community. So there are benefits to having these food programs, and I've seen them, I've witnessed them firsthand, especially for low-income Americans, marginalized Americans who aren't able to buy fruits and vegetables and know what to do with them, and healthy foods all the time. It changes, a lot of things in their relationships and their joy of life that a drug alone can't do.
Absolutely. Thank you for clarifying all that. When you bring up joy and taste, and I'm so glad you did, because I think that is so important, it reminds me that, a lot of what we need to do in this food is medicine movement, and it is a movement, is to ensure that folks have access and can afford culturally relevant diets that are comfortable to them, that are important to their communities. And I wonder who wants to comment on that. Maybe Phyllis, you want to go first?
Yes. With getting the message out to communities, outreach is a good avenue to get the message out to the community. Also, too, through schools. You can send the messages out through children, start early, through educational schools, faith-based churches, organizations. That's a good way to get the message out. Social media, that's really big with getting the message out in regards to healthy eating, healthy living, how to take care of yourself and your family, what resources are available to you through your community, so therefore you don't have to spend a lot of money, or if you don't have the money, where you can go to get help with nutritional food and also other activities you may want to incorporate into your lifestyle. So there is a whole lot of information that is available. You don't have to do some footwork, but it's worth it. The footwork is worth it. And then also, too, you have your government officials like your ANC commissioners, different politicians in your area that can help you with getting the word out, or also helping you to get to the resources that you may need to make it better for you and your family.
You're an extraordinary person because you did all of that footwork.
Yes.
And I hope it's easier in the future for other folks so that they don't have to do as much research as you did.
Well, I'm in the community. I've worked in the community for over 20 years, and I've worked in several health clinics in Ward 7 and Ward 8, the underserved community. And to get the community to come out just to get an examination, just to come and have your child get that flu shot, just to have those forms filled out, it can be very hard.
Sure.
And you have to put on a advocate hat as a community health worker to go out and be empathetic with some of the underserved communities, to let them know, I'm not above you, I'm here to help you.
Right.
And also to help them find out where the resources are so that they can take advantage of the programs that are available. And it doesn't cost anything. It doesn't cost a whole lot. You'd be surprised the insurances that will pay for and also assist you with healthy foods, with exercise programs, with Medicaid or dental, different types of social services that you may need. So it's just a matter of teaching the community, the underserved community, in regards to where you can go, how you can go, and I'm here to help you.
Fantastic. Dari and Alka, when we talk about food as medicine, one of the things we often hear about is how great the Mediterranean diet is, and it is, it's wonderful. But there are other diets from different cultures that can be equally as beneficial. How do we make sure that those diets and those cultures are sort of uplifted when we're talking about food as medicine?
I think that's a great point, because if we just recommend quinoa and beans and nuts and seeds and a salad every day for every meal for everybody, it doesn't land anywhere for many people. So without that cultural compatibility, we lose a huge opportunity when we have a captive audience, and I think that's totally critical. I think it's completely missing from medical education as well. I think it's really important. It's actually critical that those physicians and other practitioners that are in training right now receive at least core competencies, at least basic information about what the potential impact of these lifestyle interventions are. Because if you don't know that, or you don't understand that in a data-driven way, you're probably not going to spend 5 or 10 minutes during that already too short patient visit to talk about it, which means the patient walks away not thinking that's as important as the medication. And then for those that are out of training, there are a lot of educational resources out there. For example, the American College of Lifestyle Medicine has a lot of practitioner-facing and also very easily digestible and short medical curricula, but there isn't an incentive to do that, right? There isn't an incentive to go and learn that, and there isn't a mechanism to incorporate what you've learned into practice for most people. We've been able to do that because we're a value-based primary care practice, and we're intentional and different about how we approach patient care, but that's not realistic for most.
Yeah, it's very mission-driven, what you're able to do. Stephen?
Well, we're talking about variation across ethnicities and cultures, and there's another variation on this, and that is across disease states. And each disease state has a relationship to these GLP-1 drugs and has specific diets unique to each disease. And I'd like to call out registered dietitian nutritionists as part of this process.
Right.
I don't care how long you go to medical school, you'll never have the expertise of most of these trained professionals and other healthcare workers as well. So it's very important that they be brought into this process.
Fantastic. Dari, do you want to comment?
Well, I would just say, and we can expand on it, I hope, in a little bit, but there are very specific policy actions that Congress should consider, and it's basically across all of these elements. There's ways to encourage nutrition education for physicians through changes to accreditation and licensing examinations. There's ways to increase coverage for RDN counseling. RDN counseling right now only covers in most insurance programs, including Medicare, only diabetes and chronic kidney disease. At a bare minimum, we should have obesity. That's 43% of American adults, and 1 in 4 teenagers have obesity. That should be covered for RDN counseling. We have to add coverage for food as medicine programs, so for medically tailored meals and produce prescriptions and medically tailored groceries. If we do those 3 things, we have a trained physician, we have an RDN who's available, and then you actually have a prescription you can give. That's going to be an incredibly powerful complement. And while these things will cost some money, they'll cost much, much less than lifetime GLP-1s. And I think we were talking earlier with Pat about some of the cost implications, and I don't know if
Yeah,
we should
Pat,
have
please.
Yeah, and I'll just carry that through. So medication therapy management by a pharmacist to ensure that working with the physician team and the team, if you're going to prescribe something that's going to cost $1,000 a month, you need the full team to ensure they're going to stay adherent to that medication. We know they have side effects. Let's have the team help them work through that. But we also should be considering and thinking about what's the cost effectiveness here? And we have done an analysis looking at those commercially insured individuals I just talked about, following those adherent individuals in that first year. And let's be realistic about expectations for a return, because in that first year, it's not going to happen. We do not see it. Just like in the treatment of high cholesterol and hypertension, and even in diabetes, the cost offsets from the drug therapy, as much as we're investing in them, are not going to be seen in the first year. We'll be hopeful in 2, probably not. We're talking 3, 5 years. And so that's a substantial investment. And if we have, but if that lifestyle modification, that dietitian, that food as medicine is employed and covered with insurance and with policy that says it needs to be there, we can get to the point of likely deprescribing. And that is that individuals have made enough changes in their lifestyle and their exercise and their diet that we can withdraw the drug therapy that is costing so much, and we will still succeed with long-term weight loss. But we can't get there unless we have that full service package.
That whole team, that whole ecosystem approach, one thing that I've been thinking about as you all have been talking, we've mentioned registered dietitians and nutritionists, nurses and doctors, obviously. One thing that, I've heard from folks with lived experience is that it's easy for someone to tell you to eat healthy foods, but if you don't have, a proper kitchen that, with a working stove, or if you have bad teeth because you haven't gotten the, adequate dentistry over your lifetime, that can be very difficult. I'm wondering how we can sort of overcome those challenges. How do we bring the dentists in? How do we bring, other folks in who are, maybe it's landlords and others who, could make sure that people have working kitchens and, those types of things. It just interesting.
Yeah,
to me.
well, many of the Medicaid waivers that are being tested are actually doing this. And so they're combining coverage for food as medicine programming with housing support and transportation support. And the food as medicine programming often pays for these additional things. And so Project Bread is a nonprofit in Massachusetts that does a full assessment of the household, including their cooking and equipment. And so they will buy them, equipment for cooking and preparing and cooking food as part of their insurance if it's necessary. And North Carolina, which has been one of the leaders in these Medicaid waivers, just published their analysis a few months ago, showing that even accounting for all the cost of this program, the housing support, the transportation support, the food as medicine support, the program saved money per member per year. It was a net cost savings program. And I just want to emphasize that there is almost nothing in healthcare that saves money. If blood pressure screening and control does not save money, cancer screening and control does not save money, cholesterol screening and control does not save money. Almost none of it saves money. It's a good buy. We consider it a good buy. We get decent health return for $1. But if stuff saved money, we wouldn't be spending $4.3 trillion on healthcare, right? Almost always. So anything in healthcare that saves money is like this incredible diamond that you have to find and pluck and pursue.
Right.
And so these kinds of social supports done right in the right way, like you're describing, for the foundational fundamental things in healthcare can actually not only improve health and health equity, but actually save money, or at least be highly, highly cost effective,
Right.
on par with other things we consider best buys.
Sure. Phyllis or Alka, do you want to comment on that this need for other sorts of ways of looking at this?
I just want to thank all of the panelists for inviting me to this brief, because it's very important that I also be knowledgeable about my healthcare journey and how I can encourage a whole lot of my neighbors and peers and community leaders to voice, to get the message out. It's very important. Not only medication, but just like the doctor said, food. Food is medicine. Encourage someone to go and start a small garden, or go to your local grocery store and talk to the manager to see if you can have a demonstration in regards to different types of foods that you may want to invite your community to come and see and help. It's, I think it's good. I feel good. And again, I just want to say thank you so much.
You also look great. You're glowing. And thank you for being such a powerful advocate in your community. Alka, did you want to build on any of that?
I mean, I love the question about those underlying drivers of health. The same reason I love that we're focusing on nutrition and physical activity, because we're moving upstream in the problems rather than just tackling obesity or diabetes or something else. And that's critical, especially if we're talking about economic impact and everything else we've discussed today. And if we were to just do those three things well, which is a massive undertaking, understood, we would not only put a significant dent in diabetes and obesity, but that would also address 4 or 5 out of the top 7 leading causes of morbidity and mortality in the US, including heart disease, risk of stroke, things that can be catastrophic and be both life-changing and also cost-altering. So I think the farther upstream we can move, if we can choose a couple of key levers and address those, we're going to see a lot of downstream impact.
Absolutely. Thank you, Dari.
Yeah, so I think it'd be, really important to touch on some really specific pathways and things that are already going on that folks in the Senate can be thinking about. And so first, there are bipartisan bills that have been introduced that really cover these issues. And so Senator Cassidy has introduced the TROA Act, which expands coverage, among other things, for RDN counseling. There's a Medical Nutrition Therapy Act that's been introduced. TROA expands GLP-1 therapy access. Senator Cassidy and Booker and others have introduced a medically tailored meal demonstration project in Medicare for Medicare Part B to actually test medically tailored meals and look at the effects on healthcare utilization across 40 hospitals in 20 states. And that bill is actually cost neutral. There's no pay-fors that are needed because it's part of the Medicare Trust Fund. The combination of the TROA Act and the medically tailored meal bill has already come out of the full Ways and Means Committee of the House, and it passed 36-4. What do you see these days? A meaningful new bill that comes out of a major committee and passes with overwhelming bipartisan support. It almost never happens. And so the House has already passed it out of committee. It could actually pass in the lame duck period. These bills are sitting now in finance and should come out and be voted on in finance, and I think would have overwhelming bipartisan support, and then be voted on the lame duck. And in addition to those programs, I think that whether you're on an authorizing committee or on an appropriations committee, or you're just writing report language, every single time something comes up around health, every single time something comes up around GLP-1s or obesity, whether it's Medicare, Medicaid, federally qualified community healthcare centers, the VA, the Indian Health Service, the Department of Defense, the NIH, the CDC, or the FDA, every time it comes up, you should be thinking, is there language in here to be sure that I'm not just doing a Band-Aid fix, but we're creating structures and systems for wraparound lifestyle support, for food as medicine, for RDN counseling, for team-based medicine. It's not rocket science. We can actually do this, and we can actually fix this. And so I really encourage those in the Senate and it's a bipartisan support for these issues to actually get together and make this happen.
It's wonderful that there's so much bipartisan support, especially right now. Before I move to asking you all for a call to action, one thing that I really like about the food is medicine movement and what we've been talking about is that there are impacts on other areas, including regional food systems. And I'm hoping, Dari, you can talk a little bit about that.
Yeah, and others can, of course, join in. So, right now we have had sort of the last 40 years in this country kind of a vicious negative cycle around food. We're growing food to be as cheap as possible, to process it as much as possible for maximum profit, causing disease, causing rising healthcare spending, which is devastating to actually incomes and out-of-pocket spending, federal spending. We have more economic crises, more money is going to healthcare, we can pay less for food, we can pay less for housing, we can pay less for education and infrastructure, and we have this vicious cycle. Food as medicine has the opportunity to actually reverse that cycle. We start using healthcare, which is the single biggest sector of economy, a little slice of it to start paying for healthier food. We start incentivizing healthier food across the sector, from cafeterias and work sites to retailers to food manufacturers, all the way to farmers. And if we start sourcing locally and we start sourcing regionally, we can start to support American farmers and folks that want to build their specialty crops and other farms. There's examples of this. For example, Recipe for Health in Alameda County is the network of community healthcare centers, and Secretary Becerra has visited there from HHS and seen that they are using Medicaid dollars to source healthy food from all local farmers to support patients with diabetes. And so you can actually start to create this virtuous cycle where we start to invest in rural communities, start to invest in our American farmers, start to grow healthy foods that are then, actually reducing disease, lowering healthcare spending, allowing more money for education and infrastructure, defense, all the things that are priorities of everyone in the country.
It's such an exciting time to be involved in the food as medicine space. I want to ask you all for sort of a to-do list for this audience. What's your call to action? And Pat, if I could start with you.
Sure. It's policy that provides funding for what we just described. They ask for lifestyle modification, wellness programs, medication therapy management. If we're going to start someone on a GLP-1 at the investment that it's at, knowing the evidence we have for medication persistency and adherence, we need that support to be paid for the team to take care of that patient.
Thank you so much. Stephen.
I think these new drugs, the GLP-1 agonists, are distracting us by focusing our attention on weight loss and body weight. And as an older person in the room, I know that it's a lifelong process maintaining health. It's not just weight loss, but it's a focus on health. And in that context has to be lifestyle management, food as medicine, and all of these components. And life is long, and you want to be healthy. And we shouldn't be distracted by just this one particular drug.
Great point. Thank you. Alga.
I think it would be to shine a spotlight on two of the underlying, the drivers of disease in the U.S. that drive most of our healthcare costs, food, including food as medicine, physical movement, as well as the other pillars that Dari already went through. As far as getting it to the patient and to the community, I think healthcare delivery is pretty local. And so in order to actually implement that, we need to incentivize practices, providers, and other key members of that ecosystem to actually incorporate that.
Right. Thank you so much. Phyllis.
Yes, listen to your body. Take care of yourself. Plan to be in the 100 Club. You can start anytime. Be selfish sometimes. Do some things to relieve stress. Eat good food. Food is medicine. Take care.
I love Phyllis. Dari, you get the last word.
Well, I think, it's if you look, there's been many papers comparing the U.S. healthcare system to healthcare systems in other, high-income nations, and we're always at the bottom of the heap in every metric. And for food as medicine, we're actually leading the world in what's going on in this country in food as medicine. So my call to action is whether you're a policy maker in agencies, whether you're a legislator here in the Senate or in the House, whether you're a for-profit company or investor or nonprofit or a citizen, to know that there is a moment right now to grab this momentum and actually try to create a holistic healthcare system that actually deals with health and wellness and well-being, actually makes people better and happier, actually lowers healthcare spending. It's all possible, and it's all actually in our grasp, and we could do it in the next 5 or 10 years.
This is the moment. Absolutely. We have time for 1 or 2 questions. There's a roving mic that Emily has. Any questions from the audience? None at all. I hope you all feel inspired. I do. I feel really inspired by this panel, and these conversations will continue because they need to. And I hope you'll get in touch with Dari and others if you need more information. I want to thank our live stream audience for watching so intently, and I want to thank our panelists for being here. Please give them a round of applause. Thank you.